Hello, I'm Claire Ellerbrock, and I'm a psychiatric nurse practitioner in Akron, Ohio. This presentation is Leading Change, the use of integrated care to improve dual diagnosis patient outcomes. I want to start off by saying that working to improve health disparities of vulnerable populations is what led me to this project, and I'm excited to present to you today. Individuals with mental illness and addiction are particularly vulnerable populations in our society. It is well documented that individuals with severe mental illness die significantly earlier than the general population. In fact, the literature suggests that individuals with severe mental illness die an average of 25 years earlier. Similarly, individuals with substance use disorders die approximately 9 years earlier than the general population. These mortality rates are even higher for individuals with dual diagnoses of mental health issues and substance use disorders. Clearly, individuals with dual diagnoses are a particularly vulnerable population. They are at increased risk for relapse and are associated with poorer treatment prognosis and greater psychosocial impairment. Unfortunately, this population does not often receive treatment. Now, there are many reasons why individuals with dual diagnoses do not receive treatment, one of which is lack of screening and identification of mental illness in the addiction treatment setting. Not enough practice change is occurring in healthcare to address this issue. Care integration among addiction services and behavioral health services most effectively tackles this problem. The goal of this quality improvement project was to implement a pilot program to integrate mental health screening in an outpatient addiction treatment setting to identify undiagnosed mental health needs. So with an understanding with the background context I provided, the PICO question for my project is this: does the administration of mental health screening tools influence identification of undiagnosed mental health conditions among individuals with substance use disorders in the addiction treatment setting? The study design was quantitative descriptive quality improvement guided by the Plan, Do, Check, Act process, which is a 4-step cycle that allows for change, process improvement, and problem solving. The model is used for ongoing improvement. The population was adults ages 18 and older entering the addiction treatment facility. All clients admitted to the facility have diagnoses of substance use disorders, many with more than one substance use disorder diagnosis. Inclusion criteria into the study were individuals needed to have at least one substance use disorder diagnosis. Data collection tools to screen for underlying mental health conditions included 3 self-report screening questionnaires assessing depression, anxiety, and trauma, which are common among individuals with substance use disorders. The PHQ-9 scale was used to assess for depression, the GAD-9 scale was used to assess for anxiety, and the PCL-5 assessed trauma. Screening results with scores above a certain threshold were referred for further evaluation by the on-site psychiatric nurse practitioner. Quantitative data collected through the screening tools were descriptively analyzed using SPSS. Descriptive statistics were used to describe demographic information of the patient population, including age, race, gender, and substance use disorder diagnosis. The project objectives were twofold. First, that by the end of 3 months, 100% of patients entering treatment will be screened for underlying mental health conditions. And second, 100% of patients identified through screening will be referred for psychiatric evaluation by an on-site psychiatrist or psychiatric nurse practitioner. The results showed that of the total 145 individuals who entered treatment, 129 patients received the screening questionnaires, which is approximately 89% of the total who were screened for underlying mental health conditions. While the goal of screening 100% of patients was not achieved, nearly 90% of patients were, which is a significant improvement from 0% screening prior to the project's initiation. This table you see in the results section addresses the second objective, which essentially asked, did the appropriate participants receive screening tests and follow-up? As you can see from the table, 12 patients who did not meet screening threshold for further assessment still received a mental health evaluation. This may be due to patients entering treatment requesting to be seen by a psychiatric provider or other clinicians recommending clients receive evaluation by the psychiatric provider upon entry into treatment. Of the 50 patients who met screening threshold for further assessment, 28 received a subsequent mental health evaluation. However, 22 patients who met screening threshold for further assessment did not receive subsequent mental health evaluation. Now, this is a significant issue because while these 22 patients were identified as requiring further assessment, that assessment was not conducted. This was a significant limitation of this QI project, as one of the main objectives was for all individuals who were screened as needing further assessment to receive subsequent mental health evaluation. Limitations in staff resources was the primary reason for the lack of subsequent in-house mental health evaluation. The results of this QI project have a significant impact on practice. The first is that the project clearly identified a need to provide mental health services to this patient population. Approximately 39% of clients entering treatment for this QI project met screening criteria for further assessment. This is not an insignificant percentage. Additionally, the results of this project confirm and support current literature that there are high rates of mental health needs in the addiction treatment setting that need to be addressed. This project site is no exception. Lastly, the results of this QI project indicate a need to create a stronger linkaged service protocol for patients with mental health needs. For integrated care to operate effectively, there first needs to be a clear understanding of who requires mental health services as identified through screening measures. In summary, individuals with dual diagnoses are a vulnerable population. My project sought to take the initial step of care integration with identifying undiagnosed mental health conditions among patients in the addiction treatment setting. This QI project's findings justify the need for additional mental health services to address the needs of this patient population more effectively. This project serves as a foundation upon which to build more integrative services in this outpatient addiction treatment setting, involving mental health screening and linkage to mental health services to effectively treat its patients. Thank you for your time.